Call the meeting to order. I'll repeat the announcement. Director Tavantes has requested permission to attend remotely per AB 2449, which states that a board member may participate remotely per just cause should they have or be exposed to contagious illness that will keep them from attending. Before I make a motion on this, I have to ask Marcella, is there anyone in the room with you that is over 18 years old?
No, there's nobody here.
Okay, I'd like to make a motion to allow Director Tavantes to be able to attend this meeting remotely. Can I get a second on that?
Second.
Thank you.
Gallagher, thank you. Director Cox?
Yes.
Director Gallagher?
Yes.
Director Pimentel?
Yes.
Chair Minion?
Yes,
And Director Tavantes.
thank you. Can I get a roll call, please?
Yeah. Director Cox?
Here.
Director Gallagher?
Here.
Director Pimentel?
Here.
Director Tavantes?
Here.
And Chair Minion?
Here. Okay, just as a reminder, as you know, these meetings are publicly broadcast via Zoom, even in the case that the public is not physically present with us. Please consider that participants may be virtual and the meeting is recorded and posted later for public viewing. There was nothing to report out of our closed session from earlier today, and now I'll ask if there are any agenda modifications for consideration on today's agenda. No. Okay, seeing none, I'll open the public comment session on matters not on today's agenda. Rosie, any raised hands online?
Yes, I'm fine.
Anybody wishing to speak on any items? Seeing none, I'll close the public comment session for matters not on today's agenda, and I will entertain any comments from our board members. Comments. I'll just very quickly, because I know another session coming up after this, and so I'll leave some stuff for them, but just want to say congratulations to us all. This is, I believe, our first regular session since becoming owners of Watsonville Community Hospital building and grounds. And so just a lot of hard work going into that, and just everyone who was along with us for the ride and played their part. Just thank you for your work on this. So with that, I'll move on to our consent agenda. And we have 3 items on today's consent agenda. Rosie, if you could please read them off.
Yes, the first item is the minutes approval from October 25th and 30th, 2024. The second item is the policies and the policy summary approval for November 2024. And the third is the information of the designation and authority of retirement plan administrator.
Okay, any questions for staff about any of these 3 items before I open it up for public comment?
No question.
Okay, I'll open up the public comment. Rosie, any raised hands online?
No hands on line.
Anyone wishing to speak on these items? Seeing no one, I will close down the public comment session and ask for a motion on the consent calendar.
I'll move to approve.
I'll second and just ask to validate if we added the. I'm confused. I think it was the last board meeting, we had the item about property insurance.
Yeah.
And I didn't remember seeing that in the minutes. Or maybe it was. I'm mistaken. It's there. I'm
Is
good.
there
Yep,
number 10 for the
Yep.
court?
was in the wrong place. My apologies.
Oh,
Second,
okay, thank you, Director Cox. Pimentel, I will take roll. Director Cox?
Yes.
Director Gallagher?
yes.
Director Pimentel?
Yes.
Director Tavantes?
Yes.
Chair Minion?
Yes. Okay, passes unanimously. Now we'll move on to item number 4, the first item of our discussion items. And that is the Medical Executive Committee report from November 2024. This is a report that we got in closed session and now away in regular session. Are there any questions about this report from the board before I open up public comment?
No.
Seeing none, Do we have any raised hands online, Rosie?
No hands on.
Anyone wishing to speak on this item, public? Seeing none, I'll close down the public comment session for this and I'll entertain a motion for item number 4.
Move approval?
Second.
Directors Gallagher and Cox, okay, I will take roll. Director Cox?
Yes.
Director Gallagher?
Yes.
Director Pimentel?
Yes.
Director Sanchez?
Yes.
And Attorney.
Yes, item passes unanimously. We'll move on to item number 5, and it's our Chief Executive Officer report. Steve, whenever you're ready to go. All right, thank you. Rosie's gonna pull up the brief slide deck for us.
That's the one for you.
It does. Look at that. Thank you. Okay, so as you mentioned, Chair Nunez, thank you. We are now the proud owners of our property. So this was covered on November 1st. We closed on October 31st. And just wanted to have a slide in here to celebrate it. That was all. I know you already know this, but it was fun to, it was a fun couple days. It was fun to actually do this, close on this while we were in our Halloween costumes.
Yeah.
You have a picture of me on the phone with my costume on, with the bank transferring $40 million. That was good.
A lot to be thankful for.
Yeah.
Pretty good wizard work.
Yes. Okay, so our hospital dashboard for October is 3/4 done. We don't have closing on the finances yet for October because we're still working on some of the transactions related to the property purchase. So that's why it's a little bit delayed. Want to make sure we do those right. So we're doing those with working through those with the auditor. But everything else remains in good standing on the dashboard. So we're still green ahead of our 65th percentile target goal for the year for patient experience. It did come down a little bit with about 10 surveys that came back that sort of brought it down a little bit, but it brought it down about 0.5 percentage point. We're still well above the 74% target, so that's great. Our hospital acquired conditions has come down. We've had 1 a month for a couple of months now, and the goal, if you'll recall, is 16 by the end of the year. We're annualized at 18. And so we're hopeful that if we keep that at 0 or 1 for the last couple of months, we might actually hit that goal of a 50% reduction. Staff retention improved by a percentage point in October. So we went from 78% to 79%. Remember, that's all staff. That includes per diems. We'll change that up for next year. We had a very busy outpatient month in October, well ahead of budget in terms of our October volumes for outpatient, particularly in outpatient radiology. So we're about 2.3% ahead of budget now for the full year to date for the 10 months. And transfers from the hospital to another facility has stayed pretty steady at 2.5%. And would probably be 2.3 or 2.4% were it not for the PEDS psych program that we're still participating in and will continue to participate in through next year. And more measurement accountability coming in 2025. So we will be working on a health equity dashboard, trying to stay ahead of the state's requirements for health equity measurement. And we're going to try to develop a coastal healthcare dashboard. So Lupe and I have started talking about that and started talking about what are the key measures of success for the clinic as we move forward into 2025. So more to come on that in 2025. We have posted a job in for the hospital and the healthcare district. This is the Director of Government Community Relations. This individual, if we find the right person, will help the district and the hospital achieve our strategic priority of community health and advocacy. We've talked about how we really need to ramp that up now that we've gone through the bond measure and the purchase of the property. And now we really are sort of understanding some of the things ahead of us from an advocacy standpoint, getting into that space more. So helping us develop relationships with local, state, and federal legislators to advocate for our hospital, the district, and our residents here in the healthcare space, as well as leading efforts to match our services with the health needs of our community, including how we do that community health needs assessment and how we partner accordingly. And then on the finance side, identifying governmental grants and other strategic funding sources at the state and federal level that we are unaware of at this point. We feel like with that, and some of these other things, this position can pay for itself pretty quickly probably, and will be a good return on investment. We do have some really qualified candidates already and should hope to be interviewing them shortly after Thanksgiving. And here are some good reasons why we need some help with our government relations and advocacy. We've got a whole bunch of stuff coming at us that we really don't know much about yet. We have some new people in the federal government who will have a lot of sway over what happens in healthcare moving forward, and it's really hard to know what they're going to do. It's all sorts of really important things that they're going to have oversight of that could change a little or drastically, including subsidies for the Affordable Care Act, dish payments, 340B, Medicare and Medicaid, vaccines, women's rights, LGBTQ and health equity research, and the list kind of goes on. And so we are just kind of ramping up how we are getting ready for this stuff. And knowing that we need to be part of the conversation and at the table and not, and as part of the conversation, not waiting for it to be served to us. So some of the things I'm doing, in October, I did start as a new member of the Association of California Healthcare Districts Advocacy Committee. So I'm on that committee now and helping shape some of the advocacy work that the ACHD does for us on our behalf. I'll be participating in a legislative review update on new healthcare and healthcare district laws that are coming in 2025. And like I said, we're really ramping up state, local, and national advocacy whenever appropriate for the benefit of our residents. So we'll continue to do that. And there's more good news, but I'm going to let Matko take the next piece of good news and just do the rest of his report too. Take questions. But do your thing first.
Thanks. So some great news. Our leapfrog grade is up to a B, which is the first time we've been at that level for some time now. Steve and Phyllis have been looking at the reports, and we feel that we are not too far from an A at this point either. So a lot of good work to go along with the other good news that Steve's been sharing. So I'm happy to say that our leapfrog grade is a B, which is kind of the most priority. On the physician front, radiology group, I mentioned that last month. We are working, our MEC met with both the groups that we had identified, and we're working with Brad Zink to get a contract proposal in front of you all for the next board meeting. On the pharmacy front, Vaccine for Children program is now live. They provided us with about $65,000 in vaccines between the Big Fortis and Hep B vaccines. Big Fortis is a new thing for us, and we will be saving about $20,000 annually with the Hep B vaccines that we won't need to buy going forward. Halloween was eventful. Not only did we close on the hospital purchase and we were all in costume, but we also had a AT&T telephone issue lasted about 30 hours. So we had a ICS activation for a 30-hour AT&T outage. The activation team did an amazing job making sure that everything was functioning and checking all the boxes as far as communication within the building as well as outside the building. So kudos to that team. We completed a camera upgrade. So our external cameras are now 4K, and we've added coverage, including behind this building. We have the ability to log into the cameras on our cell phones at this point, so we can monitor activities on the property. On the foundation front, I want to thank Dr. Powell and Stanford Children's Hospital. They donated infant clothing for our nourish and pediatric departments. It's great work by Dr. Powell to get that allocated to us. And on the foundation's strategic retreat on November 1st, a couple of key highlights that was very successful, well attended, as some of you attended as well. Key goals coming out of there is increasing advocacy for the hospital and our programs, and continuing a partnership and support of hospital initiatives, including cancer prevention, heart health, pediatrics, mother baby, and emergency services. Jennifer would kill me if I didn't mention Holiday Hope. So we are doing our Holiday Hope children, our worker families on December 14th, and we're also conducting a bake sale on this Friday. So if you are interested, please come by, support the program. We're very excited. This is our third year of doing this, and it's just a great reward watching the kids and seeing them all come and see Santa on that morning. So thank you all. Any questions?
Any questions for Matt before we go to the nursing update?
I mean, so much good news in there. I mean, starting with leapfrog to B, and that's incredible. I'm jumping and screaming inside. I just appreciate the continued work by everybody. I think things like this a lot. Like, I'm just so overwhelmed how powerful this small group of amazing people are. So just thank you to everybody who's here. Thank you to everybody who's not here making all that happen.
Just to add on to that, I think, you know, for the leapfrog grade in particular, it's so many people 18 months ago and 24 months ago who were just grinding. So if there's any way to acknowledge all those folks on the team and all those directors, that would be, please tell them thank you, all of us.
Okay.
So, I have more good news, I guess. So we had an unannounced CDPH survey, so the California Department of Public Health last week for 2 complaints. One of them a case that was self-reported. One of them was a CMS patient complaint. So they made an unannounced survey last Wednesday. We had them on site for about 48 hours. They exited on Friday morning. So in hospital world, a 2-day complaint visit is a very good thing. So that is good news. We were expecting them because of the self-report. We've been waiting for them. We actually kind of prompted them to come because we had already been working on our action plan. Our self-reported complaint was a patient who fell and subsequently died. So we had already identified our interventions. I'm happy to say that they did not uncover anything that we had not already and proactively addressed. So I'm going to call this a win. There were no facility findings. They toured the facility, the telemetry, and the ED. They had no EOC findings, which is amazing. You know, in the state of California, representative is in your facility, they can look at anything, literally. And they were very pleased, very complimentary of our teams. They interviewed Dr. Claypool in the ED, and all went really well. We are expecting something called a 2567. It's a report of deficiency, which requires an action plan. So I imagine we will bring those things forward to the board to take a look at. Takes about 10 to 14 days. Thanksgiving holiday, I'm expecting it the first week of December. Then we'll have to respond to that. Then they will come back and survey to our audit results in order to validate that all of the corrective action plans we put into place are indeed resolved. So, but I can't reinforce, I've been in these things that have taken 10 or 14 days with multiple surveyors. So 2 days, 1 surveyor, this was a blessing. So really happy to report that. And more good news, we are developing a palliative care team for our hospital palliative care consult team. Super exciting. This is something that will benefit our community and our patients. We're looking at working with Hospice of Santa Cruz. We have some palliative care physicians who are interested in working. We have some nurses who are very interested, involving Stanford Pediatrics, looking at our pediatric community. So this is super exciting for this facility and for our community. So more to come on that. Also looking at working on our pediatric admissions issues on the 2nd floor. So getting close to that, we have pediatric strategy meeting coming up soon, looking at how do we build a more robust pediatric service on the 2nd floor with our Stanford pediatric hospitalists. So also very good news. So lots of expansion of services. Jerry Souza, our cardiovascular services director, has started. So we are working actively on our cardiovascular plan, not just about cath lab, but looking more about robust cardiovascular services for this community. So lots of good things happening.
Any questions? Marcel, I can't see you, but any questions for either 3 people?
How come you can't see me?
I'm looking at 1,000 questions in a pile right now.
We see the slide deck on the screen.
Okay, I'm fine, thank you.
Okay. Great. So I do have to open this item up to a public comment. Any raised hands online, Rosie?
Don't be so much.
Anyone wishing to speak on this item? Seeing none, I'll close down the public comment and just appreciate all 3 reports and move on to item number 6, excuse me, which is the 2025 budget update. Julie, whenever you're ready.
All right. That's over to you.
Well, much like the disclaimer I called last month, the numbers you are seeing are directionally correct, but they have changed since I put the slide deck together. They are very fluid right now. I mean, the changes are, we're just digging deep and really into the weeds and a lot of things, so they kind of change hourly, but, still within the realm of what I'm about to show you. So the next slide. So this first slide is just kind of an overview, and what you're seeing here is September year-to-date annualized with a couple of modifications for things that I know not to annualize. Then what we consider our 25 base budget, which is really before we put any initiatives on, but we do layer up with inflation factors, CDM changes, and some, productivity, our labor standards as we've refreshed our labor standards. So it's kind of ongoing operations amplified with inflation. So you can see that it on its own has a negative EBITDA of about $500,000. Then we have plenty of initiatives. I'm going to go into some of the details at a high level, but we add in the initiatives, and the final column is the 2025 budget. And it is, kind of zeroing in, sitting around the 5 million that I've been targeting as our EBITDA target for the year. A couple of highlights here, I would say is, the biggest change is really the below the line stuff with us not having the payment. We're still going to record a rent payment as though we're, the hospital's paying the district. But when it comes to a budget financials, it's gonna eliminate out because it's gonna be offsetting. So that's why we can, quickly have, $5 million EBITDA. Like this year, you can see we're annualized at about 5.2 million EBITDA, but only 1.2 net income. And that, really pretty much doubles the net income possibilities next year. Now, there are a lot of things in the initiatives that, we're trying to be realistic, sometimes conservative, but also hopeful. So, it's a little bit of everything. When you put initiatives out there, what's going to materialize. So if we can go to the next slide. So I've kind of lumped the initiatives into just some big groups. When we talk about new and increased services, kind of listed below, we're talking about getting the cath lab up and running with the roughly 480 outpatient procedures that we have planned for. We're talking about increasing our pediatric volume, potentially from other local hospitals, as well as just as we're kind of upgrading the program. We're talking about Kaiser Permanente and Salinas opening, and they've given us some projections of volumes that they think that we might see in terms of inpatient stays, ED visits, deliveries, outpatient surgeries. So that's the sort of stuff that's in that first column. And so you can see, well, I just gave the bottom line number. A lot of times the EBITDA and the operating loss was the same because they don't involve a lot of capital. So this is a $2.7 million EBITDA pickup. If I strip it all out, that's 2.7 million less EBITDA. If I cut it in half, that's 1.4. We did try to go in conservative. I didn't budget everything that they told me they could deliver, but it is still, time will tell. New CHP services, this is Dr. Ravago and bringing in the primary care. This really is about what he would do in the clinic with his existing business line. We have not tried to kind of extrapolate out what that might do to volumes in the hospital related to labs and x-rays and ancillary services. The revenue increases, this is primarily things having to do with revenue cycle improvements, which include, coding and querying physicians and making sure our documentation is solid, because sometimes it leads to better opportunities to a higher paying DRG. We've also implemented a bad debt vendor this year. So very conservatively just saying some of the stuff we've been sending to bad debt, we should start to get some collections on. And then we budgeted in the loan forgiveness that we received from the county for our line letter of credit. And the that piece, we're kind of taking a month at a time. So some of that loan forgiveness, we're taking to the income statement. It's revenue recognition. We're taking this year because the program's already started, and about 600,000 of it will take next year because the program, the time frame of that that contract goes through July. September, thank you. The expense reductions, this is a smattering of things. We've got some productivity and premium pay, overtime, reduction type opportunities. We've got the Vizient, GPO supply, program kind of more up and running, and we've been diving into the details of where some of the savings are by getting into the right tiers with vendors, where we might have some product conversion opportunities. So we've budgeted some supply savings there. Utilities, where we look at swapping out existing light fixtures for more energy efficient LED lights. There's some savings there. There's some software maintenance savings as we've done upgrades when we went to OBEX and we reduced centricity. There were some one-time expenses that we had to incur as part of that transition that don't follow. So we do have about $1.3 million in expense reductions just from those things. There's a lot of other little ones that we've pulled out as we've been scouring the different accounts and saying, oh, that was a one-time expense. That's really kind of more of the base budget. We try to pull out the one-timers. Expense increases, kind of got a placeholder in here as we're going to RADx for radiology, and knowing that what the agreement is looking like it's going to play out is at a higher cost than what we're currently we've paid, especially this year with the transition between RMG to Avis, and now this seems to be about the delta of what more it will cost us next year. And then employee retention, this is the one that is very dependent on cash. It is basically, we don't have a retirement plan for the non-union, non-exempt, highly compensated, leaders of the organization. We haven't done salary increases for 2 years. So I've done some calculations of what that could cost us. It will be very dependent on whether we have the cash to actually do it, but I wanted to have it in the budget. Next slide. Quick look, we've talked about the volumes before. When we first introduced the budget earlier in the year, that was kind of the base budget volumes. I took September again and annualized where our volumes have been, because when we did it the first time around, we had about 4 months worth of history in 2024, and now we have 9 months. So there have been some swings. Patient days were a little bit more robust in the first part of the year, a little softer over the summer. So it makes it look like a kind of larger overall projection. But we've also then added in this kind of new incremental volume from our initiatives. And that's why you see something like admissions and patient days at 14–15%. We started out, when we first looked at volumes at, roughly about a 1% admission discharge type increase. Just the shift in what we've seen volumes do since, June to now, which June would have been using on April year-to-date data. That shift is worth 3 or 4%. So the base would really be up about 5%, and then the new initiatives kind of add a new 10%. So it looks kind of drastic here. I know it gave Steve a little bit of heartburn when he first saw it, but I think he felt a little better when I talked him through it. But again, this kind of goes back to those initiatives, and it's like we're banking on kind of our best conservative estimates, but that's where the unknowns could be. Let's see. We do not have any CHP volumes here, including Dr. Robert, because at this point, this is just hospital volumes. Everything else is pretty much kind of normal business. You know, we don't expect a large, change in length of stay. We do expect to see, you know, roughly about 5 more patients a day in our average daily census by the time you get all the initiatives on. Some of those initiatives potentially have lower length of stay to just bring it down slightly. And we're hopeful for a little bit better improvement in the case mix index as we are bringing in other services. Next slide. Sorry, it gets kind of smaller as we go. I think this is me doing the last bit of work and not realizing it. These are just some high level KPIs. At the end of the day, sometimes after you've looked at so many numbers, you just kind of want to look at it from a KPI level and say, is there anything that's just way sticking out? And so I do this as my exercise to say, when I do have an increase or a decrease, do I think I have the basic storyline behind it? And so, you know, I'm at the top, I'm projecting slightly better percent collectible revenue or patient revenue. And that's because we're adding some new services. We are, the way we did our CDM change this year being more strategic, there should be some less write-offs and a little, which makes it more collectible. And then we have our revenue cycle initiatives. You know, not to go through all of these, but you can see kind of partway down, I also look at kind of the expenses and can I explain why they've either increased or decreased? You know, most of the time, like labor, some of the increases or the decrease is, you know, related to, we are trying to get more efficient. And as the more volume, sometimes volume itself can help the efficiency as well as just tighten up labor standards or tightening up overtime. And so, you know, my first blush through this was it passed my sniff test. I will continue to look at these sorts of KPIs as we hone in and put these numbers to bed. Hoping to be very close to that. Next slide. So this is kind of the final slide I have, and just to let you know what we're going to be doing between now and the next board meeting, where I do plan on bringing you a final budget for review. We have been, as I mentioned before, scouring the base budget to try to get things in or out that shouldn't be there, get them in the right places, because sometimes we have them in the wrong places, and we catch it during these reviews. We will kind of do our final validation of our productivity standards and also CHP in the districts. We do try to budget those at a detail level, but as you can imagine, they don't get nearly the attention that the hospital budget gets. So we want to complete our reviews and make sure we've done, you know, the best due diligence that we can do for those entities. The district is, you know, very few line items and expenses. That's not a heavy one. The clinic is a little heavier lift. We have been, you know, trying to figure out how we're going to account for this purchase. And, you know, I think what we've got in here is basically, we're going to keep kind of doing the rent transaction, but it's going to neutralize itself because it's eliminating entries. We're also just trying to make sure that we've only pulled out things that were MPT rent related and not things that were related to other leases that we have. So that's part of what we do there. Final reviews of the initiatives, you know, I feel pretty good about the assumptions, you know, and the confidence level to the extent that we can. And then, you know, there's a couple other initiatives we're still looking at, and like one that wasn't in here because I got the numbers very late yesterday was around our 340B program. Very excited to have that started up. That's got about a $600,000 EBITDA impact for us. We expect to save about $700,000 on pharmaceutical supplies with just the kind of current program. And we still got things that we're doing on the inpatient side. And, you know, the cost for us is just the cost of the consultant that helps us set up the program and the auditing for the program, things like that. So, you know, it's about a $600,000 favorable impact for us. So we may find a few other little things as we're, you know, finishing up here, but we may also find a few other expenses or things where we feel like we should put a little more expense in. So I'm not gonna let us get probably too far north of 5 million. And then the performance indicators, and I'll probably look at a lot more than you saw on that list, but that's kind of the final year-over-year review to say, does this feel, can I put this thing to bed? And then I'll bring it next month. Hopefully you will put it to bed. So that's it, and I'm happy to take questions.
Questions? Dr. Joe?
I heard you say these numbers change. The last time I saw the coastal health loss for the year, it was in the range of $300,000. This time it's eight something.
No, those are two different.
Good, perfect. Good enough.
Yeah, the coastal, you're correct, that the coastal health loss, it was just, and it's, that's like all the clinic, I think the number might be a little bit higher than that, but the 800,000 is just an initiative for Dr. Raviga bringing his practice on board. It's not the whole coastal health practice. You're not, I didn't show you anything that gave you that entity level detail.
All right, thanks.
Mhm.
Apples and oranges.
Any other questions?
That's the process. I presume by this point in time, all the work is now in like your shop. It's out at department land in the hospitals. They're just now, their input is fed in. I guess I'm trying to understand like how close are we? Do you think? How good do you feel about having December, because it's early, having that ready, or should we, I guess I'm planting the seed, should we be prepared? We might have to come back in January with some fine tuning.
I think we're pretty close to having the numbers. The fine tuning is sometimes when a lot of this stuff, especially in the base, has been built from the bottom up as best we can. When you do these initiatives, they're kind of done top down, so you say, okay, I'm gonna get this much, expense, but now I gotta put that in a department, and I've gotta put the revenue in a department. Sometimes that is like where there might be a little fine tuning, and you think, I wish I had that done before I present it to you, because, putting it in tele or med surge, I don't actually anticipate there's gonna be anything material that I would have to wait past December. I mean, unless something, we've been working kind of day and night on this for the last, well, for a long time, but especially the last few weeks. There's myself and to Vanessa and Ivory, we've just been heads down in this. And so I think we feel pretty confident that we have found a lot of the things. So I think we're gonna be in pretty good shape to bring it on the 20th. And that it's probably gonna be at a point where you can approve the high level and we can make it fit in the system. I will disclose that there is always more room for the interactions with leaders. We did not get nearly as much of that as I wanted to do this year, and I wasn't on the leaders, it was kind of on us.
We're busy.
It was kind of a busy year, now that you mentioned that.
Any other questions for Julie?
Before we go to public comment, I do want to just offer a comment, acknowledgement of the good work, but to your point, we're gonna have a really challenging year ahead. There's gonna be a lot of things coming from the federal government that are gonna threaten how we do things and our funding and what we can do. And so I just want to acknowledge and plant the seed that in my day job, we're already thinking about, we'll present the budget to our board in June, adopt it, but in August, we might be adopting a completely different budget. So that just to give ourselves the grace that this is our budget, our best plan based on what we do in 2024, but we don't know what's happening in 2025, and it can really alter our whole funding level, our budget plan.
Yeah, that was gonna be my question is, and maybe direction for what makes sense for our team is definitely would love to approve high level budget in December and allow you guys to move forward on that. But I remember during the time of, I think it was during the time of the pandemic, where cities and counties would come back quarterly and say, here's what we anticipate is gonna happen, and then here are my suggested allocations from this or from whatever it might be, and I know that it's a little bit different, obviously, with us. You present to us every single month, so that's, you know, that's, obviously you'll be here every month, but if we can review the budget quarterly in 2025, and just so we are constantly making shifts and stuff like that, and it could be that we go 6 months, we go 8 months, we go full 12 months, and we're still plowing ahead and nothing has changed. But whenever there is any sort of action, just want to give you guys space to be able to come back to us and say, we actually need to make this adjustment here in our budget so that we can rearrange things however we may need to, depending on immediate action that's needed. Yeah,
You know, I appreciate that, and I mean, we definitely will, because I always try to show you, you know, budget versus actual and how we're doing, and talk about what the variances are. And, you know, certainly appreciate kind of that flexibility. Probably the only thing, you know, I want to avoid getting kind of like two
sure.
sets of books, and we have financial covenants that are tied to the budget that the board approves in December. Or, you know, even if you can approve it in January, but, you know, once we do it, we have to submit that to some places we have financial covenants. They may not be as open to that flexibility.
changing there.
But they're very open to us having a very transparent conversation
Right.
about how we're doing and when we're not making it.
Mhm.
You know, and, you know, we've had that situation, you know, even in our line of credit where we weren't meeting kind of the target of the covenant. And so we talked through solutions, and we talked through, you know, waivers and things like that.
There's gonna be a lot of solution talking, I think, over the next 12
Yeah,
months. so-
no doubt about that. And certainly from our own internal planning.
Yeah.
We have to act that way. Even if we don't change the budget, we have to say, we have, you know, we've got to take action now. We can't wait until next year's budget.
Right.
So
Yeah.
we will certainly be doing that.
Then my other question was, I don't know where it falls in the budget, or maybe it's not, but the work of the foundation and how the hospital or the district is supporting the foundation financially, is that in there? And then the revenue that they're generating for us or bringing in service and stuff like that? is- or
The
not?
foundation they have a separate budget
Sure.
that they manage to. But we do support them. Their staff is our staff, so they're buried in the, you know, salary numbers, the minimal supplies that they don't purchase themselves.
Right,
The only time we basically, record any revenue from them is, and it's usually basically they're reimbursing an expense because they've raised a
Sure.
grant to buy money, to buy something, or they've raised funds to buy something. So then we say, okay, here's the invoice for that something, and they basically reimburse us. And then at that point, we recognize it as the revenue
sure.
to offset the expense. So there, you're not gonna necessarily find separate line items in here. You know, we could be budgeting for grant revenue.
Right.
We didn't specifically, we haven't specifically, you know, called that line out in this, but.
So, and I guess it would be that any of that, like, general grant revenue, general operating grants that would come in through the foundation would just be like found money for us in 2025 at this point.
Well, the foundation basically holds them in their
Sure.
budget, in their books, until we seek reimbursement.
Right,
So for us, it's, yeah, it's kind of like an offset, that the one offsets the other.
okay,
But it allows us to do things we wouldn't otherwise be able to do.
okay. I just wondering if that was included in incentives or if but that answers my question. Any other questions for open public comment? Okay, Rosie, any raised hands online for public comment? Anyone wishing to speak on this item? No? Seeing none, I will close down the public comment session and move on to item number 7. This is the Potter Valley Healthcare District Hospital Corporation bylaws approval. It's the recommendation today to pass a motion approving the PVHCD PVHC bylaw changes dated November 6, 2024. And I understand there's a supplemental item as well to supplemental material, I should say, for this item. But Steve, do you want to tee this up first?
Yeah, just a quick tee up. I think you've all seen the bylaws for a little bit that came to you in the past few days, and we're just being consistent with regulatory and industry standards to review these bylaws every 2 years. And so we are looking for any conversation that is needed to be had or approval of the bylaw updates for hospital bylaws. We've done this also in conjunction with the medical staff. Medical staff had a team that reviewed the bylaws along with their legal counsel, and making sure that we were consistent with med staff bylaws, so we didn't have anything that was in conflict between hospital bylaws and med staff bylaws. So I think we've done that work. And that was the piece that hadn't been done last time this came forward. And so look for questions and or approvals. And like you mentioned, there is a supplemental for one of the standing committees, which one of the board members presented and could probably speak to it better than I could.
So, yeah, so I think just general questions about the bylaws before I turn it over to Dr. Gallagher. And no? Okay, Joe, if you want to?
Sure. The Employee Engagement Committee has met somewhere around 5-ish times over the last 2 years, and I think it really hasn't found itself, so to speak. A couple of meetings ago, I became the interim chair, and I don't remember the details of how that happened, but I have, whether it was a sort of voluntold kind of situation, but I was happy to take the job. And as I then started to think about where we are as an organization, something that has stuck out to me was the survey numbers about employee satisfaction. So the proposed amendment has 2 significant changes to it, one of which is the existing version says meet at least yearly. This changes the meet at least quarterly. I think for momentum, getting things done, I think at that level is much more appropriate. The other is the composition of the committee. The prior version had senior execs, middle level management, supervisors, medical staff members, and frontline employees for a total of, and 2 board members for a total of 12. I thought it diluted the frontline employee input. And so my proposal is that there be 2 board members, 3 senior execs, and 7 frontline staff. There had been concern about being able to have a quorum. In fact, the last meeting was a non-meeting for lack of quorum, but elsewhere in the bylaws, section 6.2, it mentions that members can have alternates. So I think a quorum is not going to be an issue. And so my goal in this is to have sort of free communication from frontline staff to board and senior execs in both directions. And the tone I want to see is that we're all unified in trying to make this a better hospital and a better place to work. So that's the rationale behind this proposed amendment to the bylaws.
Any questions? I want to share a couple of my concerns with this one, but anything else that? So Marcella, anything? So I agree that on the first one, I think quarterly is a little onerous. I do want to, I do think that if we want stronger language of how many times the committee should meet, I would say at least twice a year. So that it's either once at the beginning of the year and then once at the middle of the year, or once in the middle of the year, once at the end of the year. Just to give flexibility for the group to be able to meet. My concern with this of basically having it be board members and then senior executives, and then none of our folks inside the hospital that are in the midline staff or directors or managers, and then including nothing but frontline staff, is that it doesn't really align with what my interpretation of this employee engagement committee was when we established it back in 2022, and that was to create a team that would have representatives from all sides of not only the healthcare district, but also the staff in the hospital, so that they can come together, come up with ideas, and then strategize about how to engage staff in the actual activities, and not necessarily use that 45 minutes, hour and a half, however long they're going to use, however long they're going to be meeting, as a place where they would do said activities, but more so strategize about what we want to do within the hospital and with our employee engagement and our surveys and those sorts of things, and for everyone's voice to feel as a part of that, as you're laying out the strategy for the upcoming year, and then reviewing what went well, what didn't go well. And so my concern about this is that if we move to something like this, it might become a grievance period for frontline staff to have some way to bypass the process that we already have in place for frontline staff to talk to their managers, who then goes up and talks to their director, and so on and so forth. And then for us, as board members. And I would like for, the C-suite, for our CEO, COO as well too, and our CNO to work on a way that we can have that interaction, whether it be direct interaction with frontline staff and the district board, instead of using this employee engagement committee as that tool. So that would be my feedback, and that's my hope that we can come to that. I understand where you're coming from, Joe, and I just appreciate you putting this forward for us to have a discussion about it. So that's so anyways, those are my comments. You're welcome to make a motion. Anyone else here as well too is welcome to make a motion or to ask questions before, or I guess we have to go out to public comment first, but any other questions or comments from board members before we go out to public comment? And then
Please. You actually like this new structure, so I appreciate Board Member Gallagher presenting this. I think how I frame this. I think as a member of the committee, we found it challenging under the Brown Act to hold meetings. And that creates a space where even we struggle in these meetings to have appropriate communication sometimes, and people feel that we're not listening to them, because as a board member, if other staff show up to this engagement committee, there's, following the Brown Act, there's really like a defined period of how they can provide public comments, and really for board members to engage on things. I liked the concept of where there would be still this element happening within the organization of the hospital, and board members would be present at that meeting. No more than two. So that can just be a regular meeting that board members are present at, versus being a Brown Act meeting and having that be a regular rhythm. That would be my preference, but I like however it shapes up. I do support the idea of having a targeted number where we do have a cross section of, I don't truly understand the definition of what frontline staff are, but having I have to imagine if you're looking at a matrix of our employees by grouping, there's more frontline staff than anything else. So it seems rational that there'd be more frontline staff in a meeting like this. So I just want to say I like the framework. I like the idea. I'm not opposed to having more frontline staff. I would respectfully ask that we go the opposite direction and have it meet annually and have it be a report back of what's happening in the hospital committee to this group. And then have the board members be invited to participate in the hospital level meeting that may occur.
Can I respond to that piece?
Sure.
So that was, and Allison can help us with this, but we did, we had that pilot time period where we thought that we could sort of have some regular hospital meetings and invite a couple board members to those meetings. And in further consultation with BBK, we decided that that was not the right way to go, and maybe Allison can give us a little bit more guidance as to why that is and kind of the challenge that that kind of structure presents, but we're coming back to, like, if we want to engage a couple of board members with employee engagement work, it should be done as a formal committee.
Yeah, I agree with that. If we have 3 or more board members at any of those meetings, it just opens it up to the Brown Act, which is, and also having this be a standing committee opens it up to the Brown Act too. Someone was, I think Marcus, you were mentioning that as well. So this right now is a Brown Act meeting. It's a standing committee. And, you know, like Steve was saying, if you just have board members attend, maybe like, you know, employee town halls or something like that to talk about issues, that could just be opening it up to the Brown Act.
Well, Allison, I'm sure you've had this experience, and I know a couple of my board members have. These things happen all the time now. Currently, there are currently my organization, prior organizations, places where employees gather in board and council members or board members do show up, and it isn't that they're part of that group there, and there's a, you know, a management of that to ensure that no more than 2 show up. So that's what I'm referring to, the practice that I've seen employed where board members can show up and can be part, you know, can be there present with staff and understanding what's going on within the organization. But not as a member of that, whatever that committee thing is. So those aren't board standing committees. It's just a place where board members are invited to attend, and then there's just a check to make sure no more than 2 show up. And typically 1, if none, show up.
Understood.
Any other comments?
Can I
Please.
reply?
Yeah,
of course, sure.
Yeah.
Having worked in the old hospital under the other governance rules and the new one, I think this organization is very top down, more so than the prior one. And in my view, if communication fails at any level, it fails. My sense is, part of my view of this is that it's a safety valve so that people can communicate to leadership. I would require that if someone's going to bring an issue, they say, you need to have already dealt with your manager about this. And this is something that then could come forward to us. I'm in contact with a fair number of employees at random, dog park, grocery store, other places, or people occasionally call me up. And one of the things that I hear regularly is people say, you know, we could be so much better than we currently are. We have ideas, we'd like to have input. And the third thought is that at the board level, we meet monthly and make decisions about long-term things. Clinically, things change hour to hour, worse, quicker. And so I think the idea of meeting once a year makes it a ceremonial committee rather than an actual sort of nuts and bolts part of the organization, or even twice a year. So those are my 2 thoughts about trying to make a broader view or paint a better picture of what I see for this committee. And I don't see it as a grievance session, but I think solving problems is really what I'm interested in. And I think I've had, like I say, several employees say to me, why can't we do X, Y, Z? And there may be very rational answers that say, no, we can't do X, Y, Z. But I think answering the question, having it heard is a significant thing for the organization.
So, but my question is, why can we not do that with managing with mid-level staff in the room so that we can have everyone be able to be represented? So that's my question.
I have to sort of answer from my own personal perspective. I grew up working class, and so I've been in situations, and it's been a very long time coming to be able to be completely fluent in meetings of leaders.
Sure.
And I think that's my perspective, that at some point I'd like to start here. And if at some point we say, yeah, this is really working well, then I think adding additional mid-level managers is a reasonable thing to do. But I think we won't get the straight story with that number of people who are of higher rank, med staff members and middle level managers in the room.
Any other questions or any other comments?
I have a quick question.
Yeah.
Is there an employee engagement committee for the hospital? Like just a hospital staff one?
Not
Because
for the
that's the other option is to have a hospital one and then also have a board member.
Right, so there's not one for the whole hospital, but Phyllis does,
Right?
Phyllis
Yeah.
does nursing, Phyllis does nursing forums, and she really a lot, most of the departments have them.
Right,
Yeah.
yes. So there is that like opportunity for feedback and input at the staff level, but
With
Yeah.
nurse.
Please.
If I may, I think there were substantially those types of things, feedback things, the blog, all of those things were in place when the survey was done. Phyllis, you were not here at that point, so these predate you. And my sense, this is a needed additional mechanism, I guess is how I view it.
Marcella, any thoughts or any questions before I open up to
No,
public?
I'm sorry. I really don't have anything to say.
I would just say I support having everyone represented and I support meeting twice a year.
Let me just jump in from
Yeah.
I do have a question about another element that I should have spoken up faster.
Yeah.
But on this topic, I want to recognize that this action isn't about employee engagement per se. It's just like, hey, review the bylaws, found these things. And I think we're identifying something that we want to spend more time in. So it's fully practical to say, we have a lot of good ideas and we don't have to solve that element of this tonight. And we can come back and amend the bylaw and change that bylaw section at the next meeting and have more time to have staff hear the feedback and come back. So I just want to call out that today's action is about the bylaws, not necessarily like what committees are we forming, what's the structure of those committees. It just happens that the bylaws talks about the committee and you bring up some really good points about how that might be formed. So I just want to acknowledge, I'm okay if we don't take action on what that solution is tonight. And we acknowledge there's some other research to be done.
Yeah, I mean, I think, as a board, I mean, the best tool that we have is to show unity, is to build consensus. And so I would like us to have a consensus before we go today to make a decision on something like that. And if we're not there, I'm with you. I'm fine with moving it on to another board meeting and revisiting it. I know that we've done about a half year of work for the, getting us to this point for the employee engagement committee, along with the pilot program and everything that we've done beforehand. And so there has been work done to get us to this point. Where, you know, the recommendation before us is to continue with what we have right now. And I think, the idea of, well, I'll open it to public comment and come back because I do see a hand raised.
And let me ask, I have
Please.
just a question in another section.
Yeah.
Six point five A Finance Committee. So maybe this is a question for Allison. The current language. Get a page number. Page 12 of the bylaws.
Oops.
My old brain is not as fast as I'd like it to be. Anyway, it had to do with the finance committee section. The finance committee section listed out the members or the examples of the members of the committee. I guess my question is, do you consider that to be an exclusive list of these are the only members who can attend, or is that an illustrative list of, you know, those are the examples of members who couldn't attend, and the board could include others?
Oh,
Should it decide in the future?
Yeah, I think the latter, because how it's drafted, it's a minimum of 2, maximum of 12, including 2 board members, senior executive, et cetera. So the including word would mean that that's, you know, that just means that that's just describing the types of people that you're looking for to serve on the committee, but it's not exclusive to other individuals.
Appreciate that. Thank you.
Okay, I think,
No, I just
And
note
these are
that,
all, these committees are all public meetings, so
Yep,
if
right.
people are not listed, they can still come.
absolutely, yeah. And I just want to note that, I don't know if it's intentional or not, but we removed the reference to Robert Roseburg's rules of orders being what we follow. And if that was intentional, that's fine. I just want to call out that it was removed from the bylaws.
I believe that was removed a while back just to give you a little bit more flexibility. That change was so long ago. Yeah,
Let me reframe that. It lives in the district, but not in the hospital. I think one of the issues with the bylaws is they talk about the same thing, but they said it differently depending on which one. So I appreciate now they're almost perfectly aligned and I love that. But I think in the work, the district referred to using Roseburg's rules of orders. The hospital does. We adopted the resolution that says we will. So I'm just noting that neither say that, then I'm okay with that. If we should, then I'd say add it in there. Somewhere we should acknowledge what we're following as a practice.
Roseburg is so bizarre.
Yeah, I don't.
I mean,
I'm
we
not-
could, Robert's Rules of Order, or, you know, it's like,
Yeah.
Roseburg, you have to look it up.
Yeah, agree.
Yeah. You don't have to specify what you're following, and if you've already passed a resolution that you are following Rosenberg,
Yeah.
that's fine. It doesn't, I think it's less common to have, whether it's Robert's Rules or Rosenberg, be baked into the bylaws now. At least recently, I don't usually see that reference anymore.
Appreciate that, yeah.
okay, good. Open it up to public comment. Rosie, I see we have one raised hand.
A hand raised online for Mary Joyce. I will. For the option to speak. Mary?
Is it Mary?
Hi.
Hi. Okay, employees carry a wealth of knowledge that has remained largely untapped, asking that they be given a chance to participate in making Watsonville Community Hospital a resounding success by putting the lessons learned on the front lines to good use. 3 examples. The CEO previously told you, Tony, that the cath lab was going to open in 2 months. You could have asked me and I would have told you that was going to happen, was not going to happen in 2 months. And if you remember, if it was a video, we told Cecilia, or the name of that lady that started saying we were going to open the cath lab and it was going to be done soon. And I asked her, who's telling you that? Because that's not going to happen. There's all these things wrong that need to be done. I don't know if you remember that. That was like 3-4 years ago. Another thing, the photo timer that Dr. Gallagher talked about, that reduces the amount of x-rays that people get by shutting off automatically. Did you know that we don't have one? That when the state came and we brought it up, there is no law. You know why there's no law? No other hospital doesn't have it. That was a decision that was made without asking frontline staff. They didn't even know what a photo timer was when they decided not to buy it. Recently, did you know that we have over 28, close to 30 women waiting for breast biopsies that we can't not do at the hospital, and they're waiting and waiting and waiting? Was the board aware of that? Women are the ones that make the decisions about what hospital their families go to. And now, you know, and we're not providing that service, and in a close-knit community like this, you know that word's getting out. Again, things that were done without input from the frontline staff. Let me see, what was the other thing? If you had 20 CEOs, you know how many managers we've had at Watsonville Radiology Department? How many managers have you had in the ER since we started? How many new managers have you had in surgery since you started? You know,
Mary, if you could wrap up your comments,
That's
your
it.
2 minutes are up.
Okay, my last minute is that I kind of sort of.
No, your 2 minutes are up. There's no other minute.
Okay,
You can let her speak. Mary, thank you for your comments. Anybody wishing to speak in the public about this, please approach the podium.
So, my name is Lizzie. I am a nurse here at Watsonville Hospital for the last more than 15 years. I've sat in on different groups and I'm a member of the Employee Engagement Committee. And I just wanted to share with you some of the things that I felt were really important about this committee to me. We have like a mix of a lot of different kinds of workers at the hospital. I wish we had more. It's a really good platform to kind of like share stories and experiences of all of the things that happen and understand more about the different roles that our coworkers have and what works well, what doesn't work well. For example, the first meeting that we had, kind of like a getting to know everybody and what is this committee even about. We all kind of shared our stories about what it was like working during COVID at the hospital. And number one, it felt really good to share that, you know, with not just, I don't know if there's any other nurses there, but with other employees, with also the management and the board members that were there. It was also really interesting to hear, you know, Kelly from the labs, you know, situation and her story about COVID, and everybody else's. And it really kind of gave some really great insight to, you know, how other employees is like daily jobs, how they work, and again, things that make them easier or harder, and you know how I can help them, you know, make their flow of work better or worse. What else? I've been reading about kind of like narrowing your vision at work or tunnel vision at work and career tunnel vision and how you can get really wrapped up on just your own job. And I think that this committee really is good about kind of bringing your head back up and seeing that we are a community, we work here together, and it's a really great place for us to just talk about that. Remember that it's not just our own jobs, but it's, you know, all of our jobs. We're all here in the community, and it's a really great platform for us to, you know, express the things that are happening that maybe sometimes it is hard to maybe go through the chain of command like you're talking about. Not in any disrespectful way at all, but it's just, it seems to be a very comfortable platform to, you know, just talk about things that you think could be better with your experience in this, you know, maybe give some suggestions on how things could be better or worse, or things that are happening that are good. It's been a really great committee so far, and we've only been able to meet a few times because it's hard with the, you know, to get quorum. But I trust that you guys will make your best decisions to go forward with however you choose to go forward with the committee. But I just really want to say it feels really good to be heard on many different levels and hear what my fellow employees have to say, or fellow work employees have to say.
Thank you, Lizzie.
Thank you.
Thank you. Anybody else wishing to speak, please?
Hi, my name is Clara Keith. I work in the OR as a scrub tech. I've been here this year 33 years and seen a lot of everything. So I am here just as Lizzie says, I think this committee would be a really good thing to support our employees, and we hear lots of things for improvements and you know, good and negative stuff. So it would be great to have a better communication and try to get a better idea, or get everybody to see better ways that are happening, you know, things that are the better stuff, because as it is now, we're just in our own little space and like little busy bees, and it would be nice to hear more positive stuff going on in this. So I'm for the meeting. Great.
Thank you. Anybody else who should speak on this item? No? Okay, I'll close on the public comment now and, I'll just add into, to my comments from before, or I guess I'll allow the rest of the board first. If you want to add any comments or ask any questions, I have a couple of questions, about the committee, before we move forward that I'd like to ask, but anything.
I just comment, I appreciate your comment, like, I think it's important for us on this particular one to be really unified in what we want out of this. I think we all want the same thing, just what's the best people to get there.
Yeah.
We all want to have a thriving hospital where people love to be here. One of our quality objectives is, you know, we're getting our strategic initiative framework, but it's, you know, we want to be an employer of choice. We just really want people to love and stay here and appreciate it. 33 years, I'll never get there. I move every 7 years. I don't know why.
I can't believe it, but it is getting harder and harder for me because I'm losing my bike.
Yeah.
And it's hard because it kills me, you know.
I think we all want that same connection with the organization, with this group and everybody. So I'd rather us do this well than do this rush.
Right.
And I'm ready to move with the bylaws and just return back on this at more time or present something more unified.
Sure. I have a couple of questions. Any other comments?
No, I agree. I think that's good.
So, we keep talking about, issues with reaching quorum. So can we talk about like what's the main issue? And is it time of day? Is it outreach? Is it interest? What have we seen so far? Not being able to reach quorum and have a meeting and
I think we've only tried one of these meetings since I've been here, so I'd probably look at Dr. Gallagher and others who have been on those meetings. Why do we think we didn't get quorum?
I mean, we were getting formed pretty easily, and then we had one meeting that we fell out of rhythm and I think we lost our way a little bit and we all got busy for different reasons. Again, I think the structure of a Brown Act committee where you have members and you have to have those members present or else you can't even meet. That structure makes it challenging. And so when we were trying to reschedule and find dates, that just got problematic and then staff got busy, we got busy. I think it's just like the inertia fell off, but it wasn't the desire to meet. The thing just, when the meetings were there, we were very tactful, strategic, and I agree. For me, it's really interesting to see how you guys all work together. But sometimes you don't get to. You're so busy, you don't get a moment to connect with each other, even understand what you're doing in the hospital.
yeah. Joe, any insight?
Yeah, I'd sort of add, I think, people are busy. These things are other times, and so employees are generally paid by the hour, whereas administrators' salary. And so this is, I'm gonna go to a meeting that I'm not getting paid for, and I should be home, and I've got all those things. So I think there's that. And then I think we tried to do this thing where we made it a non-Brown meeting so that we could sort of privately process all this. And in the period of time that it took that, I think the committee evaporated, and then we came back to say, no, we can't do that. And so in the waiting for that, I think it has. And I think in order to rekindle that, it's gonna take sort of reminder phone calls.
Sure, the outreach component.
Yeah. Okay, I think people are interested, frankly.
Yeah, I would imagine so. My sticking point is still having no representative from the mid-level management. And that the team that I worked with before I went to Community Bridges was like 12 people, or not even that, like 8 people across the county, reporters and editors and stuff like that. And so the difference between a reporter and an editor and whatever it is, it's not that big, right? But once I joined Community Bridges, you got your CEO, you got your administration, you got your program directors and so on and so forth, all the way down to your frontline staff employees as well too. And one of the most powerful tools that we have to resolve whether it be like personnel issues or whether it be to just improve the quality of the service that we have, is a committee that we have that's called the Constant Quality Improvement Committee. And we meet every single month, and it's members of every single program, which we have 10 programs, all the way from the top of that program director, all the way to the bottom of, our frontline staff of that, people who are answering the telephones at the front desk and everything like that, along with our CEO, along with our CFO. And I know that's challenging for us to do here, but we break out into different groups, an IT group, we break out into a customer service group, we break out into this other group. And it's some of the most powerful work that we do in our organization to solve some of these issues. So and it works really well because in all of these different groups, we have a person that is a part of administration, a person that's part of frontline staff, a person that is part of mid-level staff. We just do this, and it's 2 hours of our monthly schedule that we never get back, but we go in and say, I'm about to lose 2 hours of work that I need to do. You come out of it and you're like, oh, I understand now, like what I need to do in order to improve this aspect of the service delivery. It's some of the most important work that we do there, is to have that interaction between all different people, all different levels of staff, I should say. And then to come together and say, come back to the entire group and say, we came together and we focused on this one thing, and this is our action plan, or this is how we want to move forward, and we want to discuss this again next month. And so to have that sort of teamwork across an organization that works all the way from San Lorenzo Valley in the north to down to King City in the south, like, I think we could do that here. And that's something I don't want us to lose, is to have that intersectionality between all of the different departments and all the levels of service, whether it's frontline staff all the way up to our CEO. And so removing that part, excluding anyone from that group, to me, I think dilutes some of the power of this committee. So that's my biggest concern. I think, I agree that improving it or adding in more meetings a year, whether it be quarterly or whether it be whatever, we determine would be good. But I think that there's somewhere that we can meet in the middle in terms of removing a certain section of our staff and our leadership team and including them. And there's somewhere in there that we can meet. And I think maybe we have a study session about this in January or whenever it makes sense for staff to come back and to have more frontline staff, to have more mid-level staff, with the full board, and just let them know, like, hey, we're going to talk about this one issue here, and it is about this one employee engagement committee. I know that's a lot of work to ask of our leadership team, but that's what I would like us to do, so that we can move forward on this. We can have this conversation with more people in the room. We can understand, like, okay, build unity within the board on this decision. So that would be my direction on this, is that we move forward with the bylaws as they are pitched to us, and then we do some more work to finally, nail down what exactly it is we're trying to get out of this committee. So that's my recommendation. I haven't made a motion yet. I would be happy if someone would make that motion so we could talk about this a little bit more, but those are my comments. Please.
Just talk, see if there's any other questions or comments.
Marcella, any questions, any comments?
No, I've been listening.
Okay.
Well, I'll motion that we approve the bylaws as submitted and direct staff to return back in January, or January board meeting, with a discussion and recommendation for how we can retain the board's engagement with employees consistent with the employee engagement committee that we've been using before.
Does that make sense or no?
I mean,
I'm trying to stay vague, so.
the employee engagement committee is in the bylaws, right? So if we're approving the bylaws, we will have the employee engagement committee, and we'll meet at least annually. And I think, to Dr. Gallagher's point, we'll want to meet more than that, because I think that will be helpful to the extent that we can. So yeah, I'm not totally clear what you're asking of staff. I think that,
But I think
we'll have board and engagement with the employees and their engagement as part of this committee?
I think there's like, if I'm driving this by myself, there's a scenario where we meet less frequently as a Brown Act and more frequently as a committee.
Would BBK, our legal counsel has recommended that we not do that.
I respectfully disagree in the framework they're thinking of.
Okay.
So I guess I'm asking for staff to return with how might we approach this, and BPK can have an opinion about the risk mitigation that we may have, and we can be informed about what the risks are. There's a risk in everything we do. You can't eliminate all risk. And I fear that we're trying to eliminate all risk in this conversation to the detriment of what we're trying to achieve.
What are we trying to achieve? What are you saying? How might we?
I don't want to.
Interview to do what?
I mean, I would recommend staff work with the board members directly, because that's more collaborative that way. And you can, staff can get better feedback from board members, what they're individually thinking about, and see if we can coalesce around what this might be. I think you've heard comments today about affirming that we want some some clarity on the number of frontline workers, not just be a vague, these are all the people, but identify this is our target frontline workers. But I think you've heard different opinions about, we should have new management, we should have 7 frontline workers, we should meet quarterly, we should meet annually, we should meet more regularly as a non-Brown Act. So I think there's some research and understanding that might be best done one-on-one, and then coming back to the board with how we might reframe this.
Okay.
I'm trying to say vague but clear, but I think it's important to give staff some room to move on this.
So can you restate your motion?
The motion is simply to return in January with how we might better constitute the employee engagement committee, taking this feedback. And I want to end it there, because I don't want to get too specific.
So for staff to meet with board of directors individually to get their input on.
Yeah.
What
that's
is-
a good strategy.
Yeah.
That's what you would,
Sure.
all 5.
To understand, yeah, board. Or like to get out of this committee.
Taking notes.
Is there a second on that? Just to approve the bylaws as they are today and revisit the employee engagement committee in January at the earliest. Is there a second on that?
Yeah, second.
Yes.
Make a roll, Director Cox?
Yep.
Director Gallagher?
I appreciate the conversation around this, but at this point I have to vote no.
Director Wendell?
Yes.
Director Sanchez?
Good one.
Director Sanchez, you're on mute.
Get this right. Yes.
It's turning in.
Yes. Okay, so that'll bring us to the end of the Baja Valley Healthcare District Hospital Corporation meeting. So I'll adjourn the meeting